Hello, good afternoon. My name is Amy Lansky. I'm the Deputy Director for Surveillance, Epidemiology, and Laboratory Sciences in CDC's Division of HIV/AIDS Prevention, which is part of the National Center for HIV/AIDS, Viral Hepatitis, STD, and TB Prevention. It's my pleasure to welcome you here today to the first session of HIV/AIDS 30 Years of Leadership and Lessons, which is sponsored by the Sample Family Foundation and the CDC Foundation. I appreciate that you're here today and that you hiked up the hill in the heat to join us for this event. As many of you know, 2011 marks the 30-year anniversary of the first publication in CDC's Morbidity Mortality Weekly Report, or MMWR, about what came to be known as AIDS and later HIV infection. To commemorate the unwavering commitment of public health professionals, clinical care providers, and tireless advocates in the years that followed those first reports, this series will raise awareness about the bold strides we've made with the HIV/AIDS epidemic, provide a platform to examine our successes and our challenges over the past 30 years, and serve as a basis for moving forward. This lecture is one of 8 that CDC will be hosting throughout the summer to closely examine the defining moments that changed the course of the HIV/AIDS epidemic. And if you want a complete list of all 8 events in this series, you can visit the CDC website, which is cdc.gov/HIV, and there are also copies of the series at the sign-in table out front. I also was asked to remind you that there will be an evaluation form for today's session, and that will actually be very helpful to us in thinking about the future session. So if you could please fill those out before you leave today. Today's conversation will focus on an area of the HIV epidemic which has been celebrated for its successes: the prevention of mother-to-child transmission of HIV, which is also known as PMTCT. Prevention of mother-to-child transmission of HIV is hailed as one of the most successful prevention initiatives in the epidemic's history. In one of the earliest steps taken to control the epidemic, in 1985, CDC recommended against breastfeeding by HIV-infected mothers. Prior to the implementation of antiretroviral prophylaxis in 1994, nearly 25% of infants born to HIV-infected mothers in the United States became infected. Personally, I was working in the Division of Reproductive Health as a summer intern back in 1994 when the ACTG 076 trial results came out, and I still remember the energy and the enthusiasm and some of the, wow, what do we do next? And so it's been dedicated efforts from scientists, from policymakers that have turned these results into public health practice. And today, as a result of that science, policy, and advocacy groups challenging boundaries to explore effective prevention strategies, the mother-to-child transmission rate is approximately 2.5% in the United States. The estimated number of infants born in the United States with perinatally acquired HIV infection has declined from 1,650 cases in 1991 to just 131 in 2009. There were an estimated 6,000 persons under the age of 13 living with perinatally acquired infection in 2007. We estimate that the number of HIV-infected women delivering infants has increased from approximately 6,000 in the year 2000 to 8,700 in 2006. And so if we take that number of pregnant women and the reduction in the transmission rate, one can calculate that we're preventing approximately 2,000 cases of perinatally acquired HIV infection in the United States each year. With an estimated lifetime cost of HIV care at $385,000, it's clear that PMTCT can lead to significant savings in the long term. PMTCT has, to some degree, served as a model for other areas of HIV prevention, probably most notably as a model for use of antiretroviral prophylaxis, both pre and post-exposure. Our contemporary ideas about HIV testing, the opt-out approach, and the concept that testing should be a routine part of medical care were first established in PMTCT and served as a foundation for other populations. In this era of prevention through healthcare, PMTCT is a good example of healthcare-based HIV prevention. Perinatal HIV infection, however, reflects the disparities of the overall HIV epidemic. The most recent data indicate that 85% of perinatally acquired HIV diagnoses occurred in African American or Hispanic infants, but among all infants, only 37% were African American or Hispanic. The tremendous reductions in mother-to-child transmission in this country have led us to consider it possible that it could be eliminated, and we've developed a conceptual framework in which that work can be conducted. We're overseeing the national progress of the framework through our collaborations of the sort that are laid out in President Obama's National HIV/AIDS Strategy. As much progress as we've made towards elimination of mother-to-child transmission, and as much as we can foresee, it's important to remember that elimination is not something that will be accomplished only once. It will require sustained effort for as long as women are acquiring and living with HIV infection and having babies. Cases of mother-to-child transmission likely signal that systems are in need of improvement, not only for pregnant women, but for a local approach to making diagnoses and initiating and maintaining treatment plans. PMTCT is to a large degree the provision of appropriate care for HIV-infected women. A key challenge in preventing mother-to-child transmission remains the fact that too many women don't know that they are HIV positive and they're not being routinely tested when pregnant. People who are infected with HIV but not aware of it are not able to take advantage of therapies that can keep them healthy and extend their lives. We've assembled this afternoon a distinguished panel of discussants who will take us through more details of this history and help us see the future through its perspective. Our moderator for today's session is Dr. R.J. Simonds, who's the Vice President for Program Innovation and Policy at the Elizabeth Glaser Pediatric AIDS Foundation. Prior to joining the Elizabeth Glaser Foundation, he spent 20 years as a medical epidemiologist at CDC in its domestic and global AIDS programs, with a special focus on HIV prevention, care, and treatment of children. Most recently, Dr. Simonds served as Deputy Director for CDC's Global AIDS Program and as Deputy Principal for the President's Emergency Plan for AIDS Relief, or PEPFAR. He also assisted with the early development of the Global Health Initiative in 2009. Dr. Simonds received a bachelor's degree in geography from the University of California at Berkeley, earned a medical degree from the University of Hawaii, completed pediatrics residency at the Children's Hospital of Pittsburgh, and trained in CDC's Epidemic Intelligence Service. In 2010, he was honored as a finalist for a Service to America Medal, an award that celebrates federal employees for public service. Please join me in welcoming Dr. Simonds and the panel, and he will introduce the rest of the panel. Thank you.
Thank you very much, Dr. Lansky, and welcome to all of you, and thank you for coming on such a hot day to join in this discussion this afternoon. I'm particularly honored to be asked to moderate this session because I hope it's going to be both entertaining and educational and interesting for people to hear the story, the successful story of preventing mother-to-child transmission. I'm also honored to have been part of the story in my own way, and to be able to know a lot of you out there that have also been part of the story, and have a chance to reflect on what the successes have been and how we've gotten there over the past 20 to 30 years. We've got, as Dr. Lansky said, we have a wonderful panel who will not only be able to tell you facts and figures and details, but also tell you some of the human stories and be able to answer questions about what things were really like back then as the story unfolded. It is actually a story in rapid progress. Not only, as Dr. Lansky mentioned, not only is there an elimination of mother-to-child transmission effort in the United States, but it's now going worldwide. Just yesterday, world leaders, including the head of the United Nations, the former President Bill Clinton, AIDS Ambassador Eric Goosby, and many other dignitaries met in New York City and announced the launch of a new coordinated major global effort to eliminate mother-to-child transmission and save the lives of their mothers across the world over the next several years. So this is you're hearing part of the story, but I think there'll be more of the story to tell when we sit down here in 10 years and talk about the 40th anniversary. The panel that we have are three really friends of children, and not just children in general, but specifically HIV-infected children, and those children who might have been infected with HIV had their efforts to prevent those infections not been successful. I think the sum total of their career is quite long, even though they are not old. They have been working in this area a long time and have a lot of experience somehow that managed to escape the aging process. I think being, the demonstrated tenacity and commitment and passion, I'm sure will come out in their remarks. But I would like to vouch for that these are amongst, the people who have stuck with it. No one really knew how this story was going to go when it started, and being able to have the faith and commitment that we can make a difference is really the hallmark of all three of the speakers that we have today. They're all leaders in their organizations and leaders globally. You could go, in this field, you can go anywhere in the world and talk about Martha or Elaine or Chewe, and just their first name indicates who you're talking about. You've got a set of world leaders here today to tell the stories. So what I'd like to do for the session is I'm going to introduce each of the speakers briefly, but not too briefly. And then we're going to hear from each of them their piece of the story. Dr. Rogers will talk about the beginning years of discovery of AIDS in children and the events that happened in the early years of the AIDS epidemic. Dr. Abrams will discuss the response and what happens in the United States in particular following much of the successful research. And Dr. Luo will speak to the global scene and how what's happened globally in response to some of the research successes. So and then following the three speakers, we will have an open question and answer period where you can all save up your questions that you have and have a chance to quiz the experts on anything that you would like to ask them related to this topic. That I promised them that we would only allow easy questions and questions that they could answer without revealing either their age or their or any private details about how they really uncovered some of the secrets of the epidemic. Our first speaker is Dr. Martha Rogers, who started her career at CDC as the AIDS epidemic was starting at CDC, and so was amongst the early epidemiologists to investigate the first cases of whatever it was before even the word AIDS was defined, and being there in the beginning and being a trained pediatrician, she was the natural go-to person as cases of AIDS began to be reported in children in the early 1980s, and she rode that role for the rest of her career at CDC and afterwards. She led major research efforts out of CDC to define the transmission rate to children, to identify risk factors for transmission to children, to identify ways of testing HIV in young babies, as well as led the policy-making efforts to take the research findings and the things that we were discovering through epidemiologic work and listen to both the research but also the community that was that was being affected by the AIDS epidemic in children, and coming up with scientifically excellent, practical, and community-sensitive guidelines on how to deal with such difficult issues as testing back when it was not so easy to get an HIV test, and when stigma was much more of an outcome that one might expect from an HIV test than treatment and care. She also, led the effort at CDC following the 076 trial that we'll hear a little bit about, helping to set up the early surveillance systems for pediatric AIDS in the United States, and really was CDC's face of pediatric AIDS. She's now retired from CDC and is now at the Taskforce for Child Survival as their HIV/AIDS lead, and also is a clinical professor at Emory and directing the Lillian Carter Center for International Nursing. She also continues to help the CDC HIV/AIDS efforts, scientific excellence, by being a reviewer of manuscripts, the untold quality control system of CDC. Our second speaker is Elaine Abrams. Elaine is a long-standing leader both in the United States and globally as the wonderful combination of clinician, researcher, and developer of cutting-edge programs. She's as comfortable, I think, in clinics in Harlem as she is in Swaziland, and is comfortable leading the scientific groups of the NIH's research consortium as she is at the WHO in Geneva advising on policy. She's taken her experience from the front lines and from the research and really made a huge difference in the lives of children. She began her career in Harlem, starting a family care center there that helped children and families with HIV infection, and grew an academic career at the Columbia College of Physicians and Surgeons, at the Mailman School of Public Health, where she's now a professor of pediatrics and epidemiology there. She was the original brainchild behind the PMTCT Plus program, which began early on moving the agenda from just preventing transmission of HIV to children to making it a care and treatment issue of mothers, of children, and of families. And we're seeing that clearly as the way the response is going ever since. She continues to be a scientific leader, being the head of some of the research committees in the Impact Network, and is, I think her official title is the Senior Director for Research in the PMTCT Plus initiative at the International Center for AIDS Treatment and Care Program at Columbia, known as ICAP. So our third and final speaker is Dr. Chewe Luo, who, like Dr. Abrams, has combined a frontline clinical career with a research career, and then more recently being more heavily into the policy and coordination and global scene. She's a native Zambian and did practice pediatrics in both Zambia and in the UK before starting to work with UNICEF, where she's been for the past I can't say how many years because that might start to give away people's age. I promise not to use years anymore. Maybe I'm worried about my own age. I don't know. Anyway, she's worked in a number of positions in UNICEF as the country advisor in Botswana for HIV/AIDS when Botswana was scaling up their PMTCT program, was the regional advisor for the Eastern Southern Africa, based in Nairobi, and more recently she's been in UNICEF headquarters in New York City, where she's the senior advisor for HIV/AIDS, and in that role is responsible for overseeing the technical aspects of the mother-to-child prevention programs, but also the pediatric care and treatment, adolescent prevention, and treatment and care of orphans and vulnerable children. So I'm going to stop talking and allow our panelists to talk, but I did want to provide you with some of their backgrounds so that you know that these are not just talking heads, but these are real people who love children and have devoted their career to the issue that we're going to be discussing today. So without any further ado, I'll ask Dr. Rogers to take the podium and tell us about the early years.
I'm not sure why he's making such a big deal of age, but maybe I'll tell you mine pretty soon. Could I have the first slide? Let me start by thanking the organizers for inviting me to share with you the history of the public health efforts to understand and control the HIV epidemic in children. Thinking about how it was 20 to 30 years ago is a challenge, and I have to say really stretched my memory. So let me apologize at the outset if I fail to remember some things correctly or omit things that some of you may think are important. For the epidemiologist in the audience, this is a case of severe recall bias. Let me start my presentation with this single slide, this one depicting the epidemic curve of pediatric AIDS in the United States. This slide shows the rapid rise in the number of cases, followed by the rapid fall with the epidemic coming under control. As you can see from the slide, pediatric HIV disease has nearly been eliminated in the U.S. The pediatric epidemic still ranks as one of the most important battles won in the struggle against HIV/AIDS, and you'll hear that story told here today. But let me pose a premise that although children represent only a small fraction of the worldwide epidemic, the study of pediatric HIV has provided some of the most important research and undergirds our prevention efforts not only in children but also in adults. I'll return to this premise later in my talk, but let me begin at the beginning. In 1981, the year that the first cases of what would later be known as AIDS were reported, I was a newly minted 30-year-old pediatrician, do the math, and you can figure my age, beginning work at CDC. I was sure that I had the coolest job on earth, that is, an epidemic intelligence officer. I was sent to New York City for 3 weeks along with 2 other EIS officers to interview all the known living AIDS cases at the time for the first major case control study. I met Polly Thomas, the EIS officer who was assigned to the New York City Department of Health, who would later become my partner in the investigation of the pediatric component of the epidemic. But that was later to come. The first cases in children had yet to be reported at this time. That early classic case control study went on to show that the most likely cause of this mysterious new disease was an infectious agent passed by sexual contact and was passing rapidly through the sexual networks of young gay men. We would later learn of the possible bloodborne route of transmission when intravenous drug users began to also show similar signs of the illness. Still, at this point, no cases in children had been reported, and since I was a pediatrician, I was sent off to do work in other pediatric epidemics. I was later called back to the AIDS scene in 1982 by my soon-to-become mentors, Jim Curran and Harold Jaffe, when the first cases in children began to be reported. I quickly reconnected with Polly Thomas, and we established the surveillance system for children and began canvassing the New York City hospitals for cases of pediatric HIV disease. This led us to Harlem Hospital, where Elaine Abrams was also a newly minted pediatrician. So you can do the math on her age too, probably. Unlike Polly and I, Elaine was on the front line seeing case after case of babies being admitted with pneumocystis carinii pneumonia and often dying within the first few hours of their hospital admission. Scientists began to speculate on how children were getting infected since they were obviously not sexually active. The mothers of children were generally not sick, but usually came from households where someone else was sick, often the father. So the first hypothesis was that children were getting the disease from having close contact with sick household relatives. This concern led to much of the hysteria within the public that the deadly disease could be transmitted by close contact And so began the discrimination and stigma that remains a hallmark of HIV epidemic even today. Fortunately, by 1984, clever laboratorians had discovered the causative agent of this new syndrome, what would later be called human immunodeficiency virus, or HIV. We also now had a lab test for antibodies to the virus and could identify those infected before they came down with the disease. So Polly and I began to partner with clinicians like Elaine to establish the first cohort study of pregnant women infected with HIV. This study clearly indicated that the main mode of transmission to children was vertical transmission from their mothers. We also realized that not all children born to these women, however, became infected, some remaining well and losing their maternal antibody after about 1 year of age. However, since all infants were born with HIV antibodies passively transferred from their mothers, we couldn't tell which infants were going to be infected until they actually came down with the disease. We needed a better test. Turns out the labs working on HIV at CDC were housed right next door to the epidemiologists, just down the hallway, meaning that epidemiologists like me often came into contact with our fellow virologists meeting in the hallways. Just such an occurrence happened to me as I met then head of labs, Dr. Jerry Shockettman. Jerry mentioned to me that a new guy in his lab, Chewe Luo, was puttering with a new test method called polymerase chain reaction, or PCR. As he explained the methodology to me, I immediately thought of the problem we were having with identifying infected infants and arranged for Chewe to test some of the specimens that Elaine and others had been collecting. Well, the test worked, and now the method of amplifying viral DNA, known as PCR, is the mainstay of infant diagnosis, allowing pediatricians to identify infants before they become sick and treating them with life-saving antiretroviral drugs, allowing them to lead a relatively normal life. But at this point in the late 1980s, ARVs had yet to be discovered, and we still could do very little for the infants and children or their mothers. Meanwhile, hysteria ran rampant in the United States. Children with HIV were being denied entry into school, the most famous case being young Ryan White, who was expelled from his middle school because of fear of contagion. Something had to be done. I was assigned to work with Jerry Friedland and his team at Montefiore Hospital in the Bronx to investigate whether or not HIV could be transmitted through so-called casual contact, that is, living in the same household as another individual with AIDS. Our study clearly showed that the virus was not transmitted by casual contact. Despite this finding, people with AIDS were still suffering from stigma and discrimination. We needed more evidence. We got the idea to further this work on casual transmission by looking at households in which the only infected person was a young child. So we investigated these families, showing again that even young children, with all of their drooling and diapers and vomiting, did not transmit the virus to their caretakers or other siblings. These studies served as the evidence behind later legal action to end discrimination through laws such as the Americans with Disabilities Act, and served as the basis for CDC guidelines for school attendance by children with HIV and for adults in the workplace. We could finally say, yes, it was safe for these children to attend school, and yes, it was safe for adults to be in the workplace. Now, let me return to my story of the epidemic in mothers and children. Having established that children were mainly getting infected through vertical transmission, we began to mull over the possible prevention methods. This turned out to lead us down a very controversial road. Our first thought was to test all pregnant women to find out which ones were infected, letting them know about their status so they could take measures to prevent spreading the virus to their sexual partners, and so they could make more informed choices about having children. Seems like a rational approach. This brought us squarely into the sights of AIDS activist groups who were advocating against the widespread use of the HIV test. At this time, there were no ARVs, so little could be done for people who were detected as having the virus. AIDS activists were concerned, rightly so, about the test being used for discriminatory actions. So after a lot of perseverance and seemingly endless meetings, we published the first guidelines on perinatal prevention of HIV in 1985, recommending voluntary counseling and testing of pregnant women who were at high risk for the disease. These guidelines were also the first to recommend against breastfeeding. By this time, the evidence for breastfeeding as a mode of perinatal transmission was limited to the recent isolation of HIV from breast milk in one laboratory and a case report of a woman who acquired HIV from a postpartum blood transfusion and later went on to breastfeed her child. That woman was Elizabeth Glaser, who later went on to found one of the most influential nonprofit organizations to advocate for pediatric HIV disease. RJ now works for them. Although undoubtedly some children's lives were saved with the breastfeeding recommendation, you can see by the epidemic curve that these guidelines did little to stem the tide of pediatric HIV. It was not until the discovery of the first ARV, zidovudine or AZT, that things began to look up. With the publication of the results in 1994 of a remarkable clinical trial of AZT use during pregnancy, the tide of AIDS in children finally began to turn. CDC now had a highly effective prevention tool and overwhelming evidence now to be able to recommend routine voluntary HIV counseling and testing for all pregnant women, followed by AZT prophylaxis or treatment for those who are found to be infected. The end of that chapter in this story is evident in the rapidly falling incidence of pediatric AIDS, as you can see on the slide. But I will leave the details of that story to the next speaker. I would like to close my remarks with a bit of pride, not so much for myself, but for the pediatric HIV community, researchers, clinicians, public health practitioners, patients, and their families. Let me return to the premise I started with. Research with and by this community provided the basis for almost all of our most effective biomedical prevention tools that we have today. The concept that HIV infection could be prevented by ARV prophylaxis is the basis of many of our effective interventions today. Studies in children also provided indisputable evidence that HIV could not be transmitted casually, allowing people living with HIV to lead everyday lives without the possibility of discrimination. Even an American society, which at that time was highly homophobic, with disdain for other HIV high-risk groups, such as gay men and IV drug users, could not turn their hearts and minds against the children who were suffering with this terrible disease. And this gave us a foot in the door to be able to fight against the stigma and discrimination that rained down upon all of those who were affected. I was very proud to have been part of that good fight.
Nice segue into Dr. Abrams' talk on what happened next in the U.S.
It's always hard to follow Martha, but I'm also delighted to be here and very proud to be able to say that as part of this enormous public health success in seeing the curve that Martha had up in her slide. I also think I have the distinction of having been in the field for so many years that I actually know all of the CDC project officers who were in charge of the mother-child transmission study, and many of them are in various places in the world today, and I feel as though I trained them from my spot in Harlem. Last week, as I was driving to work every day, or maybe driving home, public radio station had a lot of aging HIV experts telling their stories of where they were 30 years ago and what it was like. And it certainly made me think back as well to those very bleak days when we were caring for many dying children and dying women as well. And how wonderful it is to now have a clinic filled with adolescents. It's not so wonderful to have adolescents all the time, but it certainly is a tribute to the successes. So how did we get to where we are from those 1994, even a little earlier when AZT was introduced? The achievements are really profound, and I think it's worthy of ongoing reflection of how this happened. So I'd start by saying that first and foremost, it's all about the drugs. Drug discovery, finding medications that effectively stop viral replication and block viral entry is really the axis on which all of this hangs. And I think as Martha pointed out, before drugs, we really didn't have much that we could do. We could identify, we could understand, but we couldn't do. And the discovery of AZT in particular as a drug that could improve health and reduce the risk of HIV infection to the baby was truly transformative. And then over time, we learned that AZT was good, but more was better. As drug regimens for PMTCT became more potent, we saw a concomitant drop in transmission rates among women receiving these treatments. And this is a frequently shown figure from the Women-Infant-Child Transmission, it's the Women-Infant Transmission Study, it should be WITS, which was the actual competing NIH study of mother-to-child transmission that we were always sort of battling with for fame and fortune, but together those two studies really painted the picture of mother-to-child transmission in the U.S. So the slide depicts data from this study demonstrating that MTCT rates by year of enrollment, starting in 1990 through 2003, and by maternal ARV regimen. And you could see, starting in the early 1900s, pregnant women weren't receiving any ART. AZT was introduced. That quickly went to dual therapy, often AZT and 3TC. And clearly by 2001, 2002, most women in the study were receiving combination therapy with HAART. The orange line depicts transmission rates. You can see a dramatic drop with the introduction of monotherapy around 93, 94, and then a slow drop over time as the regimens became more potent and more complex. Well, it's not really just about the drugs. There's a long list of critical scientific discoveries and technological advances that propelled efforts to successfully reduce MTCT rates. This is a short list of just some of the ones that came to mind as I was thinking about this, and I have to confess that I have a little date memory problem as well, and you'll see PCR is here, which was clearly before my time of discussion. So new drugs were identified. Efficacy, safety, and dosing were determined, including for pregnant women and for infants. By 1999, there was good evidence that elective cesarean section prior to the onset of active labor could be protective to the baby and safe for the mother. And there were fantastic advances in laboratory science, which brought us more accurate, faster ways to diagnose HIV infection and monitor HIV disease progression and efficacy. And ironically, I also remember quite well collecting bloods and spinning them in this little teeny lab in the pediatric floor of Harlem for those first studies of DNA PCR. And Dr. Rogers authored one of the first papers demonstrating that DNA PCR could be used to diagnose infant infection, and it was really a major breakthrough. There are also the studies that I just talked about that define rates, risks, timing of MTCT, as well as the natural history of HIV in pregnancy and during childhood. And these were really quite important in helping us figure out what needed to be done. But if it was only about drugs and lab tests, we wouldn't be here today celebrating the accomplishments in this arena. It was anything but. There were and have been an extraordinary set of circumstances that have ensured that these clinical trials and laboratory discoveries were successfully transformed into achievements in the field. First, scientists, clinicians, public health officials, community, and government successfully collaborated to address this public health threat, working together to achieve a common goal. And in the case of PMTCT, collectively embracing and addressing the complex health as well as psychosocial needs of very disenfranchised, poor women of color and their families living with a highly stigmatized disease. We were fortunate to have the development, publication, and frequent updating of national guidelines for PMTCT that were often echoed through state and local agencies, bringing together world experts in these areas and incorporating new findings in science as well as field experience. Guidelines were supported by regulation, legislation, and funding initiatives. For example, in New York State, HIV counseling during pregnancy became mandatory, as well as HIV testing of newborns, of women of undocumented status. There was a clear recognition that knowing HIV status was a critical piece of health information that a woman needed to know to make decisions about her own health and the health of her baby. It should also be emphasized that there's an extraordinary component of the synergy with the unprecedented funding for health services for poor people living with HIV. Through the Ryan White Care Act and other federal and local government-sponsored programs, PMTCT services for HIV-infected pregnant women and children were provided, generally free of charge, in most parts of the country. And in New York, where I worked, HIV services were almost entirely free, and pregnant women were always able to obtain PMTCT services. Finally, surveillance systems were put in place, including enhanced perinatal surveillance that served to evaluate perinatal prevention efforts and monitor implementation of the guidelines. Many states instituted programs to assess service delivery and to use data to inform program improvement. And finally, we have to take into account the courage and the willingness of all pregnant women living with HIV who engaged in PMTCT services. And our attention to PMTCT is somewhat similar. We've put in place a very effective, comprehensive safety net of different interventions, services, policies, and funding, which have been highly effective in reducing mother-to-child transmission and engaging women and families in HIV services. And the second we take our eye off the ball or stop paying attention to one component, we're likely to get a rebound effect similar to what happens when you stop your drugs. There are new challenges ahead, particularly around pregnancy and youth, among youth living with HIV. And until we can effectively prevent new infections in women, we'll need to remain vigilant and committed to our efforts to continue PMTCT services for every woman living with HIV. Each new infection at this point in a child each new HIV infection is a PMTCT failure, and it may be fair soon to say that each new infection in a woman is a prevention failure. So I look forward to the discussion ahead, and thanks.
Thank you very much, Dr. Abrams, for your review of the United States post-076 story. And now we'll have our third and final speaker, Dr. Chewe Luo, to talk about the global scene.
Thank you, Jay. It's been a long road, Elaine, but coming from Zambia, I just want to say it's been a wonderful partnership of what a North-South collaboration could be on a very important issue that affects children worldwide. I just wanted to highlight in this slide, which is very crowded, the body of evidence that we have around mother-to-child transmission. But just to say that if you look at this slide, and there are many more studies, no doubt, a lot of what I've highlighted here are studies that have happened in low and middle income countries. And what I want to emphasize, probably the untold story, is the amount of capacity development that has underpinned a lot of the evidence and generation that we have today. I just want to give my own personal story. When the PSCTG 076 results were actually released, I was working in our largest pediatric unit in Zambia. We had already started seeing a lot of babies coming to us and dying of pneumonia, diarrheal disease, failing to thrive. It was horrific. And for me, maybe I stand here today working in policy and strategy formulation with governments because it was very difficult as a pediatrician being at the receiving end of these babies, not being able to actually make the noises that were needed for us to be part of the response. But the issue was, and at the time when all this was happening, actually my sister was the Minister of Health in Zambia. And I went to her and said, look, we have to do something. And she said to me, look, if I can't give folate, micronutrients, to pregnant women, how are we ever going to test women? How are we going to ever give these drugs? And you're saying that you have to also give in during labor, intravenously. How are we ever going to do that? The other issue that was raised at the time, $1,000 per woman treatment. How are we ever going to get that type of money when Zambia doesn't even give $12 for health for anybody in Zambia? It was depressing, and we're all very desperate. But I just want to highlight the game changers for us was moving on from PSCTG. We heard the results of the Bangkok study. Nathan Sheffer released the results, 50% reduction in transmission, $50 per woman treated. We were starting to see some hope and some light, and we followed the science very carefully. There was myself in Zambia, Ruth Ndwati in Kenya, Philippa Msoke in Uganda. I can talk to my friends. We were talking about this. And it was not until we had the HIVNet 012 study results that all of us actually said, we can't shift this, we can't move this. And it was at the Global Strategies meeting in Montreal, I think it was, where we came up with a call to action to say we have to go back and push for this to happen in our countries. This slide illustrates some of the results. But again, I just want to talk about, again, the collaborative effort that has happened between the scientists in the north, scientists in the south. We have a family more or less around this. Led by WHO, we've been able to quickly translate some of these results into guidance for global action. And Elaine sitting here is a member of that group. We have Lynn Moffinson, who very actively gives us all the information in a timely manner, and we're able to actually generate these responses very quickly for countries actually to respond. And so today we can talk about elimination because the science is clear that if we all redouble our efforts, we can get to what the Western world has actually achieved. So what about the response? What actually happened? I just want to talk to three phases, and for me, what I saw sitting in Zambia is that the first phase was really the pilot phase. There was a big question around, is it even possible? Should we be testing out feasibility of integrating these interventions in our maternal child health units? That was quickly followed up by scaling up around 2004, and now we have a call to elimination of mother-to-child transmission globally. I just want to talk a little bit about what happened with the pilot projects. I think following the release of the HIVNet 012, the UN, UNFPA, UNAIDS, WHO, actually came together and formed the interagency task team to actually oversee implementation, and 11 pilot projects were actually initiated across the regions globally. I was sitting in Zambia and working through my PhD, which was actually on PMTCT, trying to answer the question of the determinants for transmission, but also looking at what would be some of the cost-effective interventions that we could already start looking at. Richard Semba had actually released a study that looked at the association of vitamin A deficiency and mother-to-child transmission. And for us, we're saying maybe this is the magic bullet. We should try out vitamin A. And as we all know, that didn't prove to be effective in the end. But UNICEF at the time, I was working at the teaching hospital, asked me whether I could lead the effort in Zambia to start thinking about feasibility. They had resources for us to set up the pilot project in Zambia. So I became the coordinator of our own effort in Zambia, started looking at rural hospitals, clinics, to try and test the hypothesis that it could be done. Just to say that in 2003, there was an evaluation that was conducted by Population Council, and the conclusions of that evaluation was that it is feasible to do this in the developing world. So following that, there was an active momentum. We did expand our interagency task team from being a UN body to a much broader body of partners that were all rallying behind the effort in developing countries. And I just want to say a lot of this was also driven by the push by PEPFAR to actually put resources behind this. And you can see a lot of the partners now on the interagency task team are actually PEPFAR funded. The High-Level Global Partners Forum in 2005, looking at what was happening in countries, some of the results we're starting to see. At that point in Abuja, we came together as implementers and actually said we have to move more towards an HIV and AIDS-free generation of children. And there was the Ministries of Health actually endorsed this, and that gave us the momentum to actually move forward with rapid scale-up of some of these programs. And the interagency task team was behind a lot of the training, developing monitoring and evaluation instruments. We were going into the countries to support governments to think through what they needed to do. CDC was instrumental in coming up with generic training materials that really transformed support to countries in terms of developing capacity of the frontline workers to deliver on these interventions. Just to say, and I'll close shortly, this is a slide from 2009 from our Universal Access Report. We are very encouraged and continue to rally behind the fact that it can be done if we all put our effort behind it. It's not easy. These results in 2009 showing that 53% of women in low and middle income countries were receiving at that time some form of ARV for mother-to-child transmission is encouraging. It's encouraging to note that the most affected region, Eastern and Southern Africa, has up to 68% of women actually getting some antiretrovirals. And sadly, though, I think we need to look at what's going on in West and Central Africa. A lot of the Central and African countries are either fragile states or they are in some type of conflict. Health systems are a lot weaker than what you see in Eastern and Southern Africa, Asia, and other places. And it's not surprising that we have such low levels of coverage. But the commitment there also needs to be much more than it is at the moment. So the global community now are rallying behind elimination. I think RJ talked about that. But I just want to end by saying It hasn't been easy. A lot of the people in this room work in Africa, they work in Asia. The systems are not as strong as they should be. Trying to deliver this intervention on the maternal child health newborn platform is very, very difficult. And what I have on that slide is just the level of coverage of some of the elements within that. We know globally that 67% of women access one antenatal clinic, antenatal visit, but when you look at 4 visits, it's much lower. It's about 48% of women that come to facilities or are assisted during delivery. And we know that some of the follow-up interventions like breastfeeding are still very, very weak. So the issue of trying to broaden this and taking HIV out of isolation and making sure that we have a much bigger portfolio that starts to address maternal and child health services and the refocus on reducing maternal mortality is where this debate has to go in the developing world. Human capital is a problem, and we have to find innovative ways of making sure that women are assisted and that services are delivered. In Malawi, for instance, most of their rural health clinics are not manned by any trained health professional. So how on earth do we hope to get to that last mile in a country like Malawi to deliver this? But what is Malawi doing is that they're investing in community health workers. So are we ready as a global community to allow those cadres of people to be able to deliver on this intervention? The policy dialogue on this is not always easy. The low coverage of antenatal services and access means that the loss to follow-up is a major issue. So as we talk about 53% coverage, do we know what that means in terms of the follow-through of those interventions? Financing is going to remain a challenge. Funding has flatlined, and we are aware of that. How do we buy more for the dollars that we're putting out there? So part of what we have to do as part of this debate is allocative efficiencies and questioning ourselves over and over whether we're putting our investments in the right interventions. Thanks.
Thank you very much, Dr. Luo, for your observations on the global scene, and to all the speakers for your sharing your experiences and your vision for the future with us. We're starting into the question and answer period, so I hope you've been thinking about your questions, and will come and not hesitate to come to the microphone to ask them. I think we have our first volunteer, but that should not...
I won't take that many minutes.
Okay, well, okay.
I'm Andy Nam. Yes, I have the privilege of old age. I think I'm the oldest one here who's been with AIDS, even before Martha. Because of the fact that one of my fellows, Jim Lansky, invited me in New Jersey, where I saw the first case, and then we found our first case in '83 with a brother having died of AIDS earlier, and our clinic since '83, '84, that's Steve Neshheim. So the other privilege is we are in Atlanta, Georgia. We're not at CDC. And I just want to say, I'm an EIS officer since '58, okay? So I love CDC, but I would want to share with you what we have done here with the many people here from Emory and Grady, Mike and Jackie and Steve and so forth, what we try to do here and what we've achieved or not achieved. So in '83, first clinic, '84, we find the first HIV in the world in Zaire in 1959. So this is 52 years. And if you want to say 30, you should leave out the HIV, because AIDS was only 81. Then we went on to be on start the AIDS Taskforce in Georgia, the second one in the country. We went to the Pediatric Red Book, try to stimulate them. They were all involved with Haemophilus vaccine, not AIDS at the time. In '85, we went to the first AIDS meeting, and I bet, Dr. Chen, you don't know where the first AIDS in Africa meeting. I was at yours in Zambia in 2000. Do you know where the first one was? In Brussels in 1985. In 87, we had, in 85, we developed the first International Interdisciplinary AIDS Foundation in Geneva to prod WHO was doing nothing. In 87, we had the first international conference on AIDS in children, adolescents, and heterosexual adults that some of the people here have been to, and about 700 people, and it was published and so on. In 86, we had gotten the first AIDS drug among the first 4 or so AIDS drug trials, where the thing they did not fund was combination therapy. We funded the other projects. And that goes to show how stupid people can be on the review boards. But that led eventually one of my fellows and now professor in pediatrics, Ray Shinazi, to develop 2 of the drugs, 3TC and the last one, which is part of Travur, whatever it's called. He claims that 80% of the world are using it. It may be 50%, but that is a big plus for the drugs. Then we went to Sweden to learn the ELISpot, which was a way to diagnose the babies, because by ELISA you couldn't, by spots you could tell the cells that the baby had as to what. And then with Chewe at CDC we compared it, and by 3 months it was as good, but PCR was better at 1 month. So we try to do that. Anyway, I will leave then to Steve Nesheim, because he took over he was a fellow with me in 93 to 95 or something like that. Anyway, and then he came back in 98 or 9. And by that time, remember, in our international thing, we already were pushing for adolescents, and we were always concerned. And now we have, I believe, one of the the greatest number of adolescents in the adolescent clinic at Ponce de Leon, where Jackie Muther and Steve was, but Jackie is still here. So we have a big clinic, still very active, and now we're seeing the children who have grown and the adolescents that are coming in fresh. And we are actively trying to work with that group, which is now, at least in developed countries, the most important one, as we have done the other. And finally, as you can see, I'm pretty passionate in my old age. Finally, my passion went to a play that was made with play cantata, some of you have heard it, called About Children of AIDS, The Grief and the Promise. There's no question, all of us here grieved when they were kids and we couldn't do anything about it, except stick needles and kept the developed kids, countries, suffering from all the drugs we were using, and eventually they would die, while the others would die earlier, but still. So the grief was there and is still there. And it's very important to, of course, go with the global program and make sure that when we prevent a mother from passing on the agent, that we treat the mother and whoever the male partner is, who is the economically the one. Otherwise, we're going to continue to have AIDS orphans. And I haven't heard a word about AIDS orphans, so could you fill us in as to where we stand with that, RJ? And Steve might fill you in from 89 on.
Well, thank you very much, Dr. Namias, for your frank and hard-hitting comments. As usual, we wouldn't expect anything else but that from you, and also for bringing the story back home to Atlanta and to the important role that Atlanta has played, even outside of CDC's role in fighting the epidemic. Maybe I'll ask, you specifically wanted some comments on orphans and where we are with that, yeah. And I think I'll ask Dr. Luo. Maybe ask Dr. Luo to address that.
Thank you. I think that's an important question. UNICEF does work on this issue, and as we do well in treatment, we hope that the burden of orphaning, and this is the unspoken problem because all of us, for some reason, are pushing hard on making sure that people get onto treatment. And there's a very narrow constituency of people trying to work on orphans and vulnerable children, and many times it's non-governmental organizations, international and national, that are trying to respond. But in terms of numbers, we do, on a regular basis, model based on the epidemic and based on what's happening in terms of the response. We try to calculate how many orphans out there actually coming out of, occurring as a result of HIV. And the sad thing, yeah, I'm actually coming to that. Sorry, I'm going around the bush here. But the recent number is actually 16 million. 16 million. 16, and 80% of those are in Africa. 1/6. So it might surprise you, but it shouldn't, because as we do better and make children live, even those that are infected, we will continue to have these children whose parents would have died, who actually feed into that pool of orphaning. We hope that as we do well on treatment, as we put more mothers on treatment, that we will reduce the burden of orphaning. I think the epidemiologists maybe can help me here, but I don't think we expect this number of children to go away soon. I think the children will continue to be there for the long term. Exactly. Exactly.
Thank you. Very important issue to track. Dr. Rogers, you'd like to?
Yeah, I'd like to, as the expert on how it was, I'm glad Andy brought up the effort here in Atlanta, because if my memory serves me well, I think Grady Hospital was actually one of the first institutions to begin routine testing of pregnant women way back in really early. It was very, very controversial, and most other hospitals were afraid to go that route, but they were very brave here and actually took that very important stand, I think, very early on, and showed us that, in fact, the world wasn't going to come to an end if you tested pregnant women. It was actually the right thing to do. So thanks for bringing up the group here.
Very good. Thank you.
Hi. So,
if you wouldn't mind introducing yourself.
Oh, yeah. Short. My name's Madison. I'm a health writer from CNN. And I was just wondering, I have a two-parter question for you. Sorry if this is very rudimentary for all the scientists. Basically, I wanted to know, are all pregnant women in the United States, are they all screened for HIV when they're pregnant? And the second parter is, let's see, are there still cases of babies being born with HIV through perinatal infection in the U.S.? And if so, even if the numbers are, pretty low, why or how does that still occur?
Elaine, would you like to?
Mm-hmm. Yeah.
So two questions. One, are all women screened for HIV during pregnancy?
Yes.
And two, are there still cases of HIV infection in children born?
Yeah.
And if so, why?
Okay. So I'm probably better poised to answer the second question. It's recommended that all women be tested during pregnancy as a standard part of care. Do all women get tested? It varies with where you live, whether you obtain prenatal care, and the local resources for testing. And probably somebody from the CDC could talk about. Okay.
Yeah, I'm not going to give the history from '89 to the present.
Just in terms of the second question, which I
Right.
think I could answer easily, that there are new infections that occur. They're rare, and they would estimate in the hundreds, probably. And again, the experts with numbers would give you better numbers, and they're considered PMTCT failures. And I think there are, I can speak specifically to New York State, where we're seeing women who were infected late in pregnancy and not necessarily identified, so might have a negative test early in pregnancy and not repeat testing. Women who become infected perhaps acutely during breastfeeding, and women who have not accessed antenatal services for a variety of reasons, ranging from cost to perhaps substance use. So those are the primary reasons. But I was just with a colleague from New Hampshire who said they had their first infection in 4 years in the state last December.
Stories like the last thing. I'm Steve Nesheim from CDC. The last sentence you said, a lot of clinicians will say it's been several years since their last transmission. There still are transmissions every year. It's been reduced about 90%, 90+% since its peak. There still are transmissions. Probably most of them are traced back to the women not being tested while pregnant, even though it's been our policy to recommend all women be tested for a long time now. The rates of testing in some of the states are rather uneven. It's very high in some states, particularly where it's required or where it's more or less required. Overall, though, it's on the order of maybe 3/4 of women are being tested if you could average the various tests. So that is probably the basic reason why they miss chances for interventions. They also might breastfeed later, that kind of a thing. So testing is the main one. Yes.
Thank you. Dr. Merman.
Great. Hi. Hello, I'm Jonathan Merman with the Division of HIV/AIDS at CDC. First, thank you all for coming and giving such wonderful presentations. I was really struck by how much you highlighted that knowing what to do doesn't always mean that we get it done. And in the current age, we have some constraints that seem to be different to some extent domestically in the U.S. and overseas. So, for example, we do have strong guidance that indicates that not only all women should be screened for HIV during pregnancy, but also that they should all receive antiretroviral therapy. And yet overseas, based on both WHO and other normative agency guidance, but also country guidance, there's been a decision implicitly made by some of the ministries of health to both reduce the CD4 count level, which would indicate antiretroviral therapy for all adults, but also for pregnant women. And I'm wondering, as the resources are leveling off, what kind of discussions are happening internationally, particularly in Africa, about balancing the availability of antiretroviral therapy for pregnant women and for all adults and children with HIV?
Thank you. I think I'll ask Chewe to...
I think this is an important question, and I'm happy that Elaine is also here because she's part of the group that develops these guidelines for WHO. First of all, WHO guidance is very much driven by evidence. And as I said in my talk, we have been following up the scientific evidence very clearly. I've had a one-to-one discussion with Lynn Moffinson myself to say, why is it that in the US you've decided to go in this direction of triple ARVs for all pregnant women? Because when we review the literature, and you've been part of the generation of the literature, CDC has done several studies on this issue, we do come to the balance of thought that for women with higher CD4s, actually giving them the intervention that we now say option A, which is an AZT backbone with nevirapine at delivery with a tail for baby, for mother, and then extended nevirapine for baby, could achieve as good a result as giving triple therapy to mothers through breastfeeding. There are operational challenges, of course, for both regimens. CD4 continues to be a barrier. I go to these facilities. I just came back from Zambia. I was in a rural district called Choma, and I spent some time with a laboratory technician at one of the clinics, and I asked her one question. What, if you had to tell me what your one wish is for PMTCT in this clinic would be, from your perspective as a laboratory person, what would that be? She told me point of care CD4. So one of the challenges is that as we develop these guidelines, the operational implications of what we are saying in those guidelines has to be considered. So am I saying that we should then give triple therapy? No, I'm saying we have to find ways of supporting programs for them to be able to deliver on what we're asking them to do. Equally, in the same locality, I went to another clinic that had no lab. So I asked them, so these are the guidelines, and Zambia has done very well in translating. I said, so what do you do when women come in? When do you start the drugs? We encourage them to go and have a CD4 test. They have no car at the clinic that can transport these mothers to the nearest place where they don't have any system in place to actually do a CD4. So you can imagine then what's happening to those mothers in those. It means that they're all getting one standard, which probably is suboptimal for women. When you look at triple therapy, I think I've come to an understanding that in America you have a patient-centered care. What we're talking about in a lot of these localities is a public health approach that you would apply as a standard. Now, equally, there are challenges in delivering 3 drugs to a woman. And from what Elaine just said at the end of her talk around stopping treatment and restarting and the issues around that, equally, trying to do this for all women that don't need treatment now would be extremely challenging in developing countries. But there are activists out there that are pushing us hard to have an equal standard between the North and I think it's important for all of us to be part of that conversation. The latest publication of treatment, the HPTN 56, I think, 52, I think it's equally pushing us harder to think about how we use the PMTCT platform as prevention. And so there will be some discussions around this, I'm sure. And I think the debate is going to move to let's treat all women with 3 drugs because there are benefits for that. But I don't think we're at a stage right now to make any recommendation on this based on the evidence that we have. I don't know, Elaine, whether you want to.
I want to answer the question a little differently because I'm not sure that's. I think part of what you're asking was the change from 200 to 350, and meaning more women eligible for therapeutic ART. And I think the dialogue is varied by country, but and many countries have actually expressed their commitment to this based on how quickly they've moved. So the new guidelines for PMTCT came out in 2009. Ethiopia has only just met to revise their guidelines. And I think from the very beginning, at least the beginning of my experience working in Africa in particular, that there hasn't been the urgency to address maternal health issues, and particularly the issues of pregnant women, that I think we had here. That really was part of what propelled the success of PMTCT. And the same for children. In Zambia, the last time I was there, the guidelines group was meeting, and there was a big question about whether to use a PI as first-line treatment for all children. And there were huge concerns about cost. And for those of you who aren't familiar with it, Kaletra is a relatively expensive drug for babies. But this is in a country that's using tenofovir for adults as its first-line therapy, which is quite costly. And when you put the cost of adult drugs next to these, you're talking about very few babies who are actually getting treatment. You begin to say, well, what are we talking about? Yeah. And I think that the specific health needs of pregnant women with HIV and children have not been center stage in many of the places I've worked in.
Thank you.
I think there are a lot of different needs, and there's malaria, there are lots of other health needs, and there's a long history to this. Well, you're not going to prevent the baby unless you treat the mother, so, yeah.
We go in and treat, and then we have a baby that's okay.
But you don't provide treatment for the adults.
And now they're orphans, and the grandma is going to die eventually. And
I just wanted to add to what you're saying. The debates and dialogue around this has been hard. I work for an organization that looks after children, which is UNICEF, and we have a huge focus on child survival as a focus. When you look at attribution, you look at what's killing children globally. There's no question that malaria kills more children, pneumonia kills more children, diarrheal disease kills more children. Attribution of HIV to mortality in Africa, for instance, is 8%, and it's much lower in many countries. So depending on where the conversations are, if you're looking at child health specialists in the Ministries of Health, they're much more focused on trying to address those other things and not HIV. And then when you look at who's driving the treatment agenda, it's adult physicians and people are setting up these adult clinics. They don't fully understand the needs of children. And it's only in the last few years, thanks to Elaine and others, that we've started setting up facilities that can adequately treat children, and these people can now start having a conversation with planners and national governments to make sure that children are on the agenda. It's not all that bad. I think the conversation is going on, but we were late in the game to try and put children on the agenda.
it's the same as we had a congressman
Right.
who was saying, why all this money for AIDS? We've got all these other medical priorities.
Right.
Remember that. Because AIDS is contagious. AIDS is going to give us more orphans and so on.
You're right.
And here we have representatives from the people who have gone overseas. I know the problem. Hey, I was born overseas. I'm an African American. Okay? So I don't understand why this did not become a priority from the very beginning. Don't you look in the future?
Thanks. I think we have time for a couple more questions, not to dismiss that as a critical issue of what the long-term vision for this has to be.
When I said I realized I had a question I didn't get a chance to answer, but before I ask it, I want to thank you all. I know 3 of you traveled for a long way to speak today, and we couldn't have asked for a better discussion. I'd want to offer that.
Thank you.
It was terrific. My question is, as some of the children, a lot of the children who were born infected have aged and are well into adulthood now, I didn't know if y'all had any combined wisdom about what you think their challenges might be as far as further transmissions or as their issues, medical issues, as the years are going by.
Let's take let's take all three of the last questions, and then we'll answer them.
So thanks. Mine, Jonathan Merman again, is really just how do you deal with the prevention paradox that we've done really well in reducing perinatal transmission in the United States, so well that there's decreasing attention and potentially decreasing resources, and we are now talking about elimination. And I'm just wondering if that's come up in your work over the past 3 decades of working in HIV, and do you have any recommendations to people who care about this issue?
Thank you. And our final question.
Okay, that's quite a series of questions. But, I guess mine's a little bit more specific and maybe not within the realm of pediatrics as much, but my name is Margaret Lampy. I'm at CDC, and my observation is that in projects we're doing throughout the country that it's not uncommon that the cases of transmission are often to women who didn't intend to have the children that they're having. And in the early days of the epidemic, it was a really touchy issue to talk about whether women should or should not be having children. But I don't see a real concerted effort here to make sure that women can have good, solid access to contraception or family planning or maximizing their health before getting pregnant. And we have a long ways to go in working with the infectious disease physicians here who are caring for HIV-infected women. I'm just curious if there are actually models from other countries to help integrate that, because we're very balkanized here in this country. That's what, in terms of clinical specialties. I'd like your thoughts on that.
Okay, so there's some tough ones. Adolescence, family planning.
I'll do the adolescents. Yeah. That's the easy one.
Okay, the rest of you can each chip in. You can each chip in your comments on any of these.
So, as I mentioned earlier, our clinics are filled with adolescents, a lot of children with perinatal disease, as well as youth acquiring HIV infection behaviorally. And I think that particularly the children with perinatal infection have huge challenges. Many of these children have been trying to take medications for their entire lives. And we're seeing, at least in our clinic, and I think everybody is, lots of the youth either beginning to get pregnant, carrying pregnancies to term, many not, but facing the similar issues around disclosure, around use of contraception. And I think they're the next great challenge. There surprisingly haven't been many transmissions among perinatal youth. I actually don't know of any that have been in the literature, but I think everybody's very vigilant about multi-drug resistance because many of these kids are living with multi-drug resistant virus. So that's the last piece of this story. Some of them are transitioning into adulthood beautifully, but many of these children aren't, having lived with this disease and many of the associated issues, not just about the disease, but impoverished families, drug use, and such. And I think seeing them all finally transition into successful adulthood is the last piece.
I'll start with the prevention paradox, and I think what's going on in the U.S. is equally going on in the developing world. And the main reason for that is that a lot of the money that's going into these programs is actually coming from countries like the U.S., and the conversation that's going on in Congress here has a real bearing on what happens to PEPFAR and the future of that, and the fact that monies are flatlined in a lot of the countries. The conversation from where I read it is that the global effort is moving much more towards global health. The conversations are moving much more towards maternal child health. And the way things are being discussed at the moment is the whole issue of trying to have better integration alignment with these other programs. And the idea is that those programs will probably be drawing much more money than what we have for HIV. The reality right now, though, is that there's no new money. A lot of people are talking about how do we use the HIV platform to deliver for other things. There have been pledges that have been made. They talk to 40 billion, except when you actually dissect it, that 40 billion is not money on the table. So the conversation, at least in the global efforts, is to have better alignment, integration of these programs, so that you can actually sustain them that way. Hopefully we can also still keep the lens on the results that we've achieved. On the family planning, we issued a paper at the end of last year. Mary Mayhew is the lead author on this, just trying to unpack elimination and what it will take globally to actually achieve it. 60% of the reduction we're talking about, and the global goal is 90% reduction, is going to have to do with providing these drugs efficiently to women, treatment plus preventive drugs. Another 16% is actually going to have to come from prevention of infection in women as well as family planning. Now, the response to date has not been to the level that we would have wanted it, because the global strategy for PMTCT has always included family planning. The support for a much more accelerated effort behind this has not always been matched by the resources that we need. And so hopefully with this new agenda, new platform for elimination, and the new platform also for focusing much more on strengthening maternal health programs, we can see a real effort behind making sure that women actually do receive these interventions. the conversations is around what are we talking about? We're talking about integrating it in all HIV/AIDS programs like VCT, ART programs, as well as PMTCT programs. Whether that's going to achieve the results that we need, we have to wait and see. Family planning is a difficult one, I think. Whether we talk about HIV or no HIV, it's a very difficult agenda, I think. I won't try and answer the adolescent issue because for us, we're very scared, especially in Africa, because we don't have systems to carry through these children. I used to work in a sickle cell clinic in Zambia, and children were scared to be transitioned to adult clinics because there was no adolescent care at all. And so we ended up keeping our children with us until they were ready to go themselves. So I don't know how we're going to deal with this adolescent issue, but it's something that's coming up and is being discussed because I think it's a question of time. We'll have to set up the systems that we need to be able to care through the children that we'll be saving.
Thank you. I hate to leave anybody standing. We do need to wrap up, but I think if we have a quick question. We're happy.
I won't talk as long as that other old person.
Okay. Thank you.
I'm Jackie Muther from the Grady IDP, and I've been hearing the terminology around adolescents for the last year as two categories, perinatally infected and behaviorally infected. Well, let's remember that we have kids that are in neither group. Know who they are? They're those who have been sexually abused by mama's boyfriend or whatever else. So behaviorally infected, I think, is kind of a judgmental term that shouldn't be applied really to anybody, frankly, because it could be anybody's behavior. And especially with young gay youth or MSMs, they often are taken advantage of too. So I just want to throw that out there that I think that terminology needs to be revisited a little bit so we don't judge.
Thank you very much. I think the issue of terminology is never a trivial issue because it really frames how we talk about and look at issues, and I think that's one of the other lessons as we've roll out an important public health program in the context of very sensitive and politically charged issues that we do need to pay attention to language and how we're speaking about them. Well, we've gone over time, which I apologize for. I presume anybody who really wanted to leave earlier would have. So I think you're all here as volunteers at this point. But we do need to wrap up. And I think we've heard a couple of major themes. One, we've had some people who have the ability to reflect on several decades worth of history to share those with us and allow us to think about and revisit some of the issues that are still relevant today and how they played out. And then I think we've been challenged by our success to do more, to do things in a better way, and to take the successes and not only extend them geographically, but programmatically to see how we can build on the successful approach to preventing children from becoming infected to, as Dr. Nami is reminding us, to keeping their families healthy and preventing children from becoming orphans. We have we can build on the programs that we have to do more in these ways. We've also got challenges, as Dr. Merman mentioned, about keeping the eye on the ball, and I think needing to be smart and figure out how to keep the engagement with those who make policy decisions, those who make budget decisions, and keep ahead of them. And I think part of that will be on what we can build and what more things we can gain on this success, and not just keep it walled off as, okay, we've been there, done that, and move on, but to see what more can we do to build on what we've done already. So I want to thank everyone for their attention, for coming, and for your questions and engagement. You may have questions that you didn't want to stand up and ask, and I think if you can catch the audience before, or the speakers before they go, they probably would be willing to answer those for you. So, I want to end by reminding you of two things. One, there are evaluation forms somewhere. They may have been on your seats, or they may be outside, and maybe someone can tell me where they are. They're out front, and I know at least some of you are epidemiologists and know the value of data in providing feedback to programs on how they can do better. And so this is the first session of a series of sessions, and your feedback can help to continue to have excellent sessions going forward. We have, I think the next one is next week, Thursday, where we have a Nobel Prize winning speaker whose name I can never pronounce, but I think if you come here, she will be able to pronounce it for you. And I believe that's Francois Barré-Sinousset, they tell me. And she will be speaking on Thursday evening, I believe, at Emory. And if you need any further information about that, I think the website and that stuff is all outside. So thank you, everybody, and have a safe drive, and don't get too hot out there. Thank you.